I'm Leslie Young, ABMP Vice President Communication and editor of Massage and Bodywork magazine. I'm honored to introduce our next presenter. Whitney Lowe is one of the first individuals who helped orient me to the field. He's a longtime contributor to Massage and Bodywork magazine and currently writes a column titled Science of Nerves. Whitney's career spans nearly 3 decades and includes extensive clinical work, research, publication, and teaching in advanced massage principles. He offers orthopedic massage certification and is the author of Orthopedic Assessment in Massage Therapy, widely used in schools and by professionals. Students enjoy Whitney's accessible, well-designed trainings, as well as the personal attention they get in his online trainings. Today, Whitney helps us demystify complex neck conditions in his session at the ABMP Head and Neck Summit. Understanding how to evaluate the client's condition is paramount to effective treatment, and Whitney will show us how. I'm sure you'll learn a great deal from his session. Please continue to enjoy Whitney's wisdom in Massage and Bodywork magazine.
Hi, my name is Whitney Lowe, and I'd like to welcome you to the 2016 ABMP Head and Neck Summit. It's quite an honor to be part of this wonderful group of presenters giving you some great information here today about treating pain problems in the head and neck region. In this presentation, we're going to look at some key anatomical factors that help guide and to help you determine what kind of problems you're going to be addressing and some of the things that will be happening with each of those different pathologies in the head and neck region. It's really important to have a good understanding of many of these anatomical factors and some of the biomechanical characteristics in this area because they play a big part in guiding the type of injury conditions that you're likely to encounter. So we'll look at a number of these different structures, some key assessment strategies, and also discuss some primary treatment processes that will be very helpful for addressing a wide variety of pain and injury conditions in this area. So let's get started. So we're going to take a look at some key anatomical structures here that may play a role in a number of pain and injury complaints around the cervical region. The first thing I want to call your attention to is the deepest structures there, the structure of the bones of this region, because they do play a part in a lot of different things that we're going to be addressing as a massage therapist. This area is not very structurally sound from the skeletal standpoint, and as a result, we rely a great deal on soft tissues to give us some additional stability in this area. Let's take a look here. You can see the bones of the cervical region and the contact surface between adjacent vertebrae as we sort of move our friend around here. And do take note here too, the head has got a significant amount of weight, but the contact point of where the head is articulating with the cervical vertebra is actually very small. It's just this little amount here right at the atlanto-occipital joint. So there's not a lot of contact surface here, and we rely on structures such as the joint capsules, various stabilizing ligament structures, and a number of others to provide additional stability in this region. Let's take a look at some of the real important muscles that play a role in stability in this region too. They also have a lot to do with creating and producing movement here between the atlas and the occiput. You may remember from your anatomical studies back in school having to remember all of these muscle names, and these were some of the most challenging ones. I always think about this as being interesting because you have some of these small, really short, some of the smallest and shortest muscles in the body with some of the most long and obnoxious names to them, like rectus capitis posterior minor and rectus capitis posterior major. These are very important muscles. They also play a big role in a lot of headache pain complaints because trigger point pain referral patterns can often go into the cranium from these very short muscles, so they're pretty significant. The challenge that we often have in trying to address these muscles from a treatment perspective is some of the overlying tissues that can get in the way. Let's take a look, for example. If we look at some of the most superficial tissues, we of course have the large trapezius, the upper trapezius section that lies directly over this area. We also have the splenius capitis highlighted here, and also a little bit around the side. We have splenius capitis right here. We have semispinalis capitis that we had highlighted right here. Splenius capitis around the side, which is an ipsilateral rotator. We're going to take a look at it in just a few moments as well. Now, trying to work through some of these larger muscles to get to those suboccipital muscles is a little challenging. We don't want to just have to keep pushing on there with greater and greater pressure, so we often try to find some other helpful ways that will let us get in there a little bit more effectively. working on these tissues right here, there's a concern that I want you to be aware of that may be a potential problem in this area. Let's take this semispinalis off for just a second and take a look once again back at our superficial, or our deep suboccipital group here. We have arterial structures in this area as well. And let's remove those muscles for a second so we can take a good look at those arteries. You'll notice the vertebral arteries travel through these small holes or foramen in the transverse process. We can see them right here. It's an unusual pattern for the arteries to be traveling through this little hole in the bone in the vertebrae themselves. Very few places do you see this kind of thing happening in the body. Now we have a problem here in the structure and the arrangement of these vertebral arteries, in that they go up on each side and then they blend together and eventually form the basilar artery as they go into the cranium. Now if you put pressure in this area, you can cause a blockage of blood flow from those vertebral arteries into the brain. This can also happen if a person tilts their head back like that in full extension, or sometimes tilts it back and rotates it in a direction like that. That can cause a compression right in this area right here of those vertebral arteries. And when it does cause compression of those vertebral arteries, that may block blood flow to the brain, and the person may feel dizzy or lightheaded, or they may have ringing in their ears or buzzing or seeing stars. Any type of neurological sensation like that that causes them to be somewhat disoriented can be a problem, so you don't want to do that. So a couple of things that you can do to keep that from being a problem is, just as a general guideline, it's a good idea not to work both sides of the neck in this region at the same time. Let's look at those muscles once again. We're often trying to focus on these suboccipital muscles, and you can see how they're lying directly over those vertebral arteries. Let's just fade them for a second. And we can see those vertebral arteries right in this whole area here, with those muscles faded looking over the top of them. So you can see the pressure in this area could potentially press on these sensitive arterial structures. So as I mentioned, just try not to press both sides at the same time, and make sure you let your client know if you're working on any of those deep suboccipital muscles, to let you know if they have any sensations of dizziness, lightheadedness, or anything that might indicate some type of vascular compression. So in addition to just putting static compression in this area with your fingertips, there's a number of other things that you can do to work these suboccipital muscles. One of the ways that I like to do this is with a little active engagement technique that gets a little bit of motion going in those tissues as you're working them with your pressure, either from a thumb or a fingertip or some other kind of small contact surface. Let's take a look at that technique and what that would look like.
While quite small, the 4 suboccipital muscles on each side of the neck are important in treating head and neck pain. The suboccipital muscles include the rectus capitis posterior minor, rectus capitis posterior major, obliquus capitis inferior, and obliquus capitis superior. Active engagement techniques are an effective method for addressing pain and dysfunction in the suboccipital muscles, which can be difficult to treat because they are small and lie deep to a number of other cervical muscles. Be sure the posterior cervical muscles are somewhat relaxed prior to applying this technique. Begin with one hand under the client's head so that you can move the client's head into a tilting motion, just simple flexion and extension at the atlanto-occipital joint. Instruct the client to tilt their head back as if looking up high straight behind them. Hold that, and now slowly let that go. As the client slowly lets it go, perform a short stripping motion just between the first 2 vertebrae on the suboccipital muscles. Once again, hold that there, and slowly let that go. This technique should be repeated several times, engaging the contraction each time, and gradually move out along the whole length of the suboccipital muscles on each side.
So that's a great way to work those suboccipital muscles. And now let's take a look at some other of these deep structures that we may want to pay attention to as well. I'll take the muscles off of here for just a moment and put our connective tissues back on here. Remember, at each joint of the spine, These are called the zygapophyseal or facet joints. Each one of these has a capsule, a joint capsule, which helps to guide and limit motion of that particular joint. When an individual is subjected to significant violent forces in the neck, like in a sporting event or automobile accident with whiplash, you can have a sprain or injury to these facet joints or zygapophyseal joints that may cause significant pain and discomfort to be felt deep in the cervical region. That pain and discomfort would often be felt with both active and passive movements, because it's going to happen regardless of whether their muscles are engaged or not. As long as they're moving their head and neck around and straining those tissues that have been damaged, you may get pain recreated from zygapophyseal or facet joint pain. Sometimes these joints also are subjected to arthritic changes. You often hear of people saying they've got arthritis in their neck, or they've been told they have arthritis in their neck from just aging many times. Those arthritic changes may affect the actual joint contact surface, but they may also be predominantly affecting the capsules, because these zygapophyseal or facet joint capsules are richly innervated, meaning there's a lot of nerve endings in there. So when there's a pain problem, it can be pretty significant. The pain can be quite prominent for those felt in that area. Problem with massage for addressing something like this is it's really hard to get to those joint capsules, and there isn't that much that we can really do for them. So this is something where we might want to try some other alternative approaches where we'll be working on some of the other surrounding tissues as well. Now, one of the key things that people are concerned about in the cervical region is the plethora of nerve structures that are in this area, because they often hear about things like disc herniations that may be a problem and may be a potential contraindication, or something that somebody's been told they have a herniated disc, and that's a key part of their neck pain. So let's just take a quick look at what's happening there with those disc herniations and revisit the anatomical structures in this area. So again, taking a look at the lateral aspect of the cervical region here, we can see these intervertebral discs between each of the adjacent vertebrae. They're primarily designed to cushion and absorb compressive loads in the cervical vertebra. We take a look here for a second. Let's move some of these vertebrae out of the way, and we can sort of see deep down inside that disc, and note that the disc is composed of these sort of circular fibers known as the annulus fibrosus, and the inner portion, which is a sort of gel-like substance in the middle, is the nucleus pulposus. So the annulus fibrosus surrounds that nucleus pulposus, and it's designed to provide a sort of shock absorbing and cushioning effect. You can see an example in this schematic here of what the sort of relationship is between those fibers of the annulus fibrosus and the nucleus pulposus. On the left, you can see in a relaxed or unloaded vertebra, those structures are sort of expanded, but once a load is put on there, the nucleus pulposus pushes out against the outer fibers of the annulus fibrosus, and this is what helps provide the cushioning and shock absorption. Now, of course, it is that same sort of cushioning effect and the sort of pressure that's applied to the disc that causes potential problems with disc herniation problems. Once we add the nerve structures in here, we can see, if we sort of zoom in on this and take a close look, we can see how close those nerve roots are to where the disc is pressing or potentially protruding in there. I'll spin that slowly around to the side here. And you can see, for example, like right here is where that nerve root is, and it's very close proximity to where the disc may be pressing out in this area. And that's where you're going to have a disc herniation, potentially causing problems, pressing on nerve roots, which will then be felt somewhere else. Now, most likely, as you can see, a lot of these nerve roots, especially in the lower cervical area, feed into the brachial plexus, and we'll be looking at it in a little bit more detail here in just a few moments. These nerve roots feed into the brachial plexus, and consequently, when there's pressure on those nerve roots, pain is felt down the lower extremity, not just in the neck, or excuse me, not the lower extremity, down the upper extremity, the length of it where those nerve fibers are associated. One of the most important things that we've learned about disc herniations in the last several years is that for many years, disc herniation was blamed for the cause of a lot of both neck and low back pain. Once we had learned that disc herniations occur and they may cause pressure in or around nerve roots, there was a lot of suspicion that those same disc herniations were causing numerous pain and injury complaints. What we really have learned since then is that many people have herniated discs and no pain whatsoever. So just the presence of a disc herniation does not necessarily mean it's the cause of the individual's pain. Even if they have pain and we know and confirmed they've had a disc herniation with an MRI or something like that, it doesn't necessarily mean that disc herniation is causing the pain. You have to look at a lot of other clinical factors and make sure that the entire picture really makes sense for having a disc herniation problem, because there can easily be a disc herniation and no pain. So it's not always a guarantee that that's a direct cause of a person's pain. One of the things to also be cautious of, we can't necessarily know this, but just so that you're aware when you're working on people, disc herniations aren't the only thing that cause pressure on nerve roots and cause significant pain sensations or other pins and needles or numbness to be felt down the upper extremity. You can have other obstructions in this area, such as spinal tumors that may be right adjacent to where the nerve root is exiting the intervertebral foramen, bone spurs. A number of other obstructions that may occur in this area can also produce those same type of pain and injury complaints. So be aware that this is something that you may need to be looking out for as well. One of the big challenges that we have in trying to identify if there is nerve compression occurring at the nerve root or level, or is it somewhere else down the length of the nerve, is, how do we figure that out? Sometimes signs and symptoms from the clinical evaluation can really help you in that process. You may remember seeing pictures like this, map of dermatomes. The dermatome is an area of skin that's innervated by one single nerve root. You might remember this from your anatomy texts. So for example, if there is pressure on the C7 nerve root, right where it comes out adjacent to the C7 vertebra, this is the area of skin that's innervated by that nerve root. This yellow area is indicated, that's the particular area of skin that would be innervated by that particular nerve root. So if someone has pain or injury, or pain or pins and needles or some other kind of sensations that are felt in that entire area, all the way from the back of the shoulder down through the hand and into the fingertips, that's a good indication that something's going on at the nerve root level. Conversely, if they have a pain that's only felt in the hand, and we're seeing an image here right now of the cutaneous innervation of the hand in those different regions, right here the yellow or golden color indicates the area innervated by the ulnar nerve alone, and this is just the portion of the hand. So if those sensations are felt only in the hand, this may be indicative of a problem that's pressing on the ulnar nerve somewhere farther along its length. Maybe that's between the anterior and middle scalene muscles, or maybe it's underneath the pectoralis minor muscle, or even somewhere else farther down the upper arm. This would be an indication of pain in a peripheral area pressing on a nerve root, giving those sensations only in this area that we've referred to as the area of cutaneous innervation in the hand. It's different than the nerve root, and this will tell us a little bit more about where we want to focus our treatment if we're trying to address those particular types of nerve compression symptoms. So now let's take a look at some of the other deep structures here in the cervical region associated predominantly with maintaining our key structure and our key alignment in the cervical region and resisting excessive forces that the neck and head are subjected to. We saw earlier the facet joint capsules that help guide and limit motion at each of the individual joints. There's some other important ligament structures which may be injured in and around the cervical region I want to call your attention to. So let's take a second to flip around a little bit. Take our friend and turn him just a little bit here and zoom in a little. In between each of the adjacent spinous processes are what we refer to as the interspinous ligaments. There's also ligamentous structure running along the top surface here, just the very upper edge of this, referred to in a lot of anatomical texts. You'll see this spelled out separately as the supraspinous ligament. And in the cervical region, this supraspinous ligament has fanned out and become the ligamentum nuchae, which is a very dense, thick structure on the posterior aspect of the cervical region. You can feel that ligamentum nuchae on yourself if you simply put your fingertips on the back side of your neck right down the midline and then just tilt your head forward, and you'll feel that thick dense structure come up right in between your fingers, and that's that nuchal ligament, or the ligamentum nuchae. Its primary function as we evolved from quadrupeds, you can imagine, is very thick and heavy in quadrupeds because it's helpful in holding the head up because they're horizontal in the gravity plane. Once we eventually evolved into standing upright, that ligament's role in holding the head up was not so crucial any longer because gravity was helping to hold us in the upright position, but it still is a residual structure in there, and it also does allow for a number of muscle attachments directly on those soft tissues as well. Now, some other structures you don't think about as much, but they're important to be aware of for maintaining stability in the cervical region, and they may play a part in a number of pain and injury conditions, involve the very deep longitudinal ligaments that run the whole length of the spine. You have two of these, the anterior and posterior longitudinal ligaments. Let's take a look at them individually. You can see here in the cervical region, we've highlighted the anterior longitudinal ligament, and it's designed to limit certain types of motions in the cervical region and also prevent the discs from sort of protruding. Well, they do prevent the discs from protruding forward, not necessarily that that's their function, but they do work to help prevent the discs from protruding forward. They give a great deal of additional stability in that cervical region by being a broad, flat band directly on the front side of the cervical vertebra to sort of all help them maintain their alignment, because when you put a significant weight on the end of this cervical structure, and you put like a 12 to 14 pound head on the end of it, as you move the head around in various different positions, there's a lot of forces that those structures are subjected to. So these longitudinal ligaments help maintain that stability in the area. A very important structure on the opposite side is the posterior longitudinal ligament. It's harder to see because it's deep inside the vertebral canal, right adjacent to the spinal cord. But let's take a look inside and see if we can see it. Now we're peering through some openings between adjacent cervical vertebrae here, and we can see that posterior longitudinal ligament deep inside the spinal cord. Let me highlight it right here, and you can see now it's highlighted in green, and it's running deep inside the spinal cord. This will get a little bit messy if we add the nervous tissues on there, but you can see with them on there, the spinal cord is lying directly over that posterior longitudinal ligament. The reason that is significant is, let's take a look here for a moment. If we take these vertebrae off, we can see that posterior longitudinal ligament, and also look at where it is in relation to the intervertebral disc. You can see that ligament is helping to prevent the disc from protruding in a posterior direction. So it's got a key stabilizing role to help that disc from pushing out straight posteriorly, because if the disc is subjected to excessive forces and it gets squeezed and pushed in a posterior direction, it will push directly on the spinal cord, and that's going to be really bad, of course. So this posterior longitudinal ligament does provide some additional resistance to that straight posterior protrusion. The downside of that is, since it does prevent the disc from going straight posteriorly, the disc will then tend to press out in a more posterior and lateral direction, and that's when it tends to press on the nerve roots. So now that we've looked at some of the deep connective tissues in this area, let's revisit some of the nerve structures that are in here that are particularly sensitive. This is very important to look at in the head and neck region because there's so many nerves that come out of this area, and they play a big role in many of the complaints that are felt both in the cervical region as well as down the upper extremity. So let's take a brief look at a schematic here first before we look at some of these deep anatomical structures and review some of the key facets of nerve structure, because it's really highly specific in this area, and the more you understand about what how these structures work, how they're positioned, what you're going to be adjacent to when you're working in some of these areas, the more effective you can be in addressing them. So over here on the right, we see the spinal cord, and down below is the red indicators, sort of the little red lines coming in there on the ventral root. And then on the posterior side is the dorsal root. So the ventral root, remember, is primarily the signals going out of the spinal cord to the muscles and other effector tissues in the body. So the motor signals that go from the brain down through the spinal cord and tell the muscles to move and do things are being sent out through that ventral root. The sensory information, such as touch, pressure, sensation, thermal reception, all of those sensory signals are coming in with those blue lines through the dorsal root. So remember, we have both a dorsal and a ventral ramus if you look over on the left part of this diagram. The ventral ramus is what we focus the majority of our attention on because this is what makes up all the big and major nerve structures that exit the cervical region. So when we talk about the brachial plexus and the major nerve roots, we're always looking at those ventral rami predominantly as the main tissues that innervate that area. We often forget about the dorsal ramus, which actually are these very small nerve structures that go directly posterior and innervate many of these tissues, the muscles and tissues in the posterior cervical region. Let's take a quick look at what they look like anatomically. In this diagram, the dorsal rami are easier to see just right below the cervical region in the upper thoracic area. Let's take a look here. We can see them as these small branches that are coming out right here off that major nerve trunk that's exiting through the intervertebral foramen. So the dorsal rami is coming out the back here just like this on these small individual nerve fibers. So it's innervating those muscles, those paraspinal muscles that run alongside the spine, as well as giving superficial sensory sensation in a lot of those tissues that innervate the structures right alongside and parallel to the spine as well. So when you're working on these tissues, you're doing work right alongside the spine. You're working those dorsal rami, and you can really help reduce a lot of pain sensations and complaints that may be felt right alongside the spine by helping to loosen up and free up some of these tissues as well. Now, one of the things that garners a great deal of attention in the in the cervical region is the brachial plexus. When we talk about nerve structures, there's a lot of attention focused on the brachial plexus. Let's zoom into that for just a moment here. In fact, let's highlight it a little bit. So if we look at just the brachial plexus alone, we can see it's composed of a number of different nerve roots from the C5 to the T1 level, and they eventually branch out into numerous different nerve structures that go down the upper extremity. Back here in our anatomical model, we can see there's many nerve roots of that brachial plexus that have to go through small passages right adjacent to bones and other soft tissues, and this is where we have a number of our nerve compression problems that occur. For example, if we start putting a few of those other muscle tissues on here, we can see there's not a lot of space for that brachial plexus to pass between some of those structures, such as the anterior and middle scalene muscles. Looking right here, we can see how those nerves pass right in between the anterior and middle scalene muscles, and this is, of course, one of the regions where they may potentially get entrapped. In this anatomical model, there looks like a good bit more space there, but there's also a potential for them to get entrapped underneath the clavicle up against the upper rib cage. We can see that area right here where they may be susceptible to compression in this area. Also overlying these muscles is the pectoralis minor muscle, which we see highlighted right here. The pectoralis minor, and if we just sort of fade it out, we can see how that brachial plexus goes right underneath the pectoralis minor muscle and can be compressed against the upper rib cage if that muscle is hypertonic. Also, certain positions like forward rolled shoulders or bad posture, slumped shoulders, may contribute to additional compression in this area, so it's a good idea to work that pectoralis minor muscle whenever you can. That pectoralis minor muscle is not really easy to work a lot of times because you have, of course, the large pectoralis major overlying it, so you have to go through that muscle. So instead of trying to just push harder and apply more pressure on there, there's a couple other ways that you can do that. Here's a nice little technique that I like using for addressing the pectoralis minor, especially in situations of potential nerve compression, because it really helps get that muscle worked much more effectively, since it's really difficult to stretch the pectoralis minor by itself. This is a pin and stretch technique that will help encourage elongation in those pectoralis minor fibers. Let's take a look.
The pectoralis minor is important to treat in certain neck pathologies. The pectoralis minor can be involved in various postural distortions and variations of thoracic outlet syndrome, where nerves or vascular structures are pinned by the muscle against the upper rib cage. Because it's deep to the pectoralis major, it can be challenging to treat. This active pin and stretch technique reduces tension in the pectoralis minor without putting excessive pressure in this area and further compromising nerves that may be compressed. Have your client reach down towards the knee, and this puts the pectoralis minor in a shortened position. Take your fingertips and apply pressure directly on the pectoralis minor muscle. But make sure that your pressure does not aggravate any of the existing neurological symptoms. While maintaining pressure, instruct the client to lift their shoulder up towards the ear as if hiking the shoulder. In so doing, we pin and stretch the pectoralis minor, applying a short static compression or a short stripping technique on the muscle during the technique. Once again, if you will reach down towards your knee, pin the tissues of the pectoralis minor in this position, and now lift the shoulder up towards this ear and a short stripping technique on that pectoralis minor. This is a very effective way to reduce tension in the pectoralis minor muscle. Just make sure that none of your pressure aggravates any of the existing neurological symptoms.
Now back at the brachial plexus for a moment, let's take a look at another thing in terms of what really causes certain types of injuries to occur in this area. One of the things that occurs frequently with brachial plexus injuries is lateral whiplash injuries. So when the body or the head is hit from the side and it causes this rapid elongation of those tissues on the side of the neck, the brachial plexus and the nerve structures can often be over-lengthened, pulled, stretched, and sometimes damaged as a result of that. Let's take a look at this example from automobile test crash dummies, and you can see how during the crash part of the impact, there is a rapid lateral flexion of the cervical region to the side. And this is what happens in side impact automobile accidents. We also see these kind of forces applied a great deal in sporting events where a person may be, tackled or hit from the side, and it causes that rapid lateral movement of the cervical region to that area. So these are some of the factors that may lead to brachial plexus traction injuries, not compression injuries, but traction or overstretching. The problem with traction injuries in the brachial plexus is there's not much you can do for them except give them time to heal. We don't want to put additional compression on those structures, so we don't want to do a lot of work directly over this area because it can further aggravate the irritated nerve structures. When you have developed a traction injury that's overstretched nerve tissues, about the only thing that you can do is give it appropriate time to heal and reduce some of the other irritating factors that may be present in structures and tissues around that area. Now, while the brachial plexus gets the large amount of attention for compression problems in this area, remember there's other structures that may be irritated or involved in this area as well. Looking just above this whole brachial plexus, for example, we here have the supraclavicular nerve complex that's coming out of the cervical plexus, not the brachial plexus, but the cervical plexus, and innervating many of the tissues across the top of the shoulder. So a person with upper shoulder and neck pain might be having problems with this supraclavicular nerve as opposed to something going on in some of the other structures that are around there. So do remember you have some of these other more superficial nerve structures that may be involved in numerous pain and injury complaints as well. You have other tissues that are coming off of fibers right adjacent to the brachial plexus. For example, another tissue that's often compressed in this region but doesn't get as much attention is the long thoracic nerve. It's highlighted with a slightly different yellow color, and you can see the little call out pointing to it. Let's highlight that and isolate that long thoracic nerve so we can take a look at it more specifically. Now you can see what that nerve looks just by itself here. The long thoracic nerve is predominantly a motor nerve that goes to the serratus anterior muscle. And that's very important because if that long thoracic nerve is compressed, you might have alterations in shoulder function because the serratus anterior is not working properly during shoulder abduction movements. And that can cause a number of other complaint problems. So when we talk about brachial plexus compression, you may have a number of other things like long thoracic nerve involvement that's affecting the way the serratus anterior works that are also part of the problem that you'll want to focus on as well. Now, since we're massage therapists, we tend to focus a great deal on muscle structure. So I just want to highlight some of the other key structures, the muscle structures in this area that we may want to pay attention to with various pain and injury complaints around the neck region. Earlier, we spoke about nerve compression problems that may occur because of tightness in the scalene muscles. And the scalenes are difficult to treat in this area because we don't want to put a lot of pressure directly in this region that might adversely affect the nerves that are in the area. Also, we have sensitive arterial structures in there, such as the carotid artery. Just as a quick reminder, let's put those arterial structures up here and look how close they are to the scalene muscles. So here we see the arterial structures, and let's highlight right here the common carotid artery, and look how close it is to the anterior scalene muscles. So here's anterior scalene right here, and the common carotid artery is lying almost directly over the top of it. So you really want to be careful about putting a lot of adverse pressure directly on the scalene muscles because of the proximity of the carotid artery. Now, if we zoom up here a little bit, if we work higher up in this area, this is an area called the carotid sinus where we can see the splitting of the carotid artery into the internal carotid here and the external carotid here. This area of the carotid sinus where the two split is an area where you may get blood clot formation sometimes. So this is another place to be really careful with any kind of deep pressure that you're putting in this area so that you don't dislodge a clot that then floats to the brain or causes other types of severe problems with your client. So we've got the carotid artery, we have the main nerve tissues in there. How do we work this area without putting adverse pressure on them and causing additional irritations in there? One of the ways that I've found to do this very effectively is with active engagement techniques, where you're engaging the muscle in additional effort at the same time that you're working on it. And by magnifying the muscle's effort while you're working on it, you increase a lot of the neurological input in there that overrides many of the pain sensations. It also increases the density of that muscle by forcing it in a contraction while you're working on it. That means you don't have to press as hard to get the same types of good effects into the individual and the deeper muscle fibers. Let's take a look at what that might look like with the active engagement technique for the anterior scalene muscles. Now you'll note in mention of this as we look over this, you'll want to be careful for doing this type of technique with anybody that has any kind of symptoms of that vertebrobasilar insufficiency we talked about earlier. That was the potential for compressing the vertebral arteries behind the or just above the C1 vertebra between that and the occiput. So if your client is having any kind of sensations of dizziness, vertigo, ringing in the ears, you don't want to continue doing this particular technique with them. But it's a really effective way to address tightness in some of the anterior musculature, such as the scalenes. Let's take a look.
It's important to treat the anterior neck muscles, such as the scalenes, in postural disorders and neck injury conditions. To avoid pressing harder into the sensitive structures in this region, use active engagement to maximize effectiveness. For this technique, the client's head is going to be dropped off the end of the table. So have your client slide up so that the head can be in a position off the end of the table. If the client's uncomfortable in this position, a bolster can be used underneath the upper back region to do the same procedure. Bring the client's head into full flexion. From this position, the scalene muscles are in a slightly shortened position. Place your fingertips on the edge of the scalene muscles and have the client engage a contraction. If you will, hold your head up. The client will hold the head up, but keep your hand underneath their head so that they'll know that you're back there for protection. And now slowly let that go. As the client slowly lets the head go, there's an eccentric contraction in the scalene muscles, and you're performing a short stripping technique along the length of them. We'll perform that again several times. If you will, lift your head up. That's good. My hand stays behind here just for safety's sake, and the fingertips press on the scalenes. Now slowly let that go. Good. This can be repeated several times for maximum effectiveness. Don't perform this technique if there's any concern that your client might have vertebrobasilar insufficiency.
Now, who do you know that hasn't felt that pain in the neck sensation of the pain on the back side of their neck? Often it's associated with forward head posture, tilting your head down, or the long periods of trying to keep in a good upright position. Maybe as you're bent over a desk all day, or you're doing something in your occupation. Or we as massage therapists are looking down at our clients all day long. All these kinds of things can cause additional irritation of those structures on the back side of the neck. So we have muscles such as the semispinalis that we looked at earlier, the splenius capitis, and of course the erector spinae group, all on the back side of the neck there. These are muscles that all can have chronic tightness, myofascial trigger points, and cause a lot of significant pain and discomfort in the area. We have a similar problem that we saw earlier in that it's hard to put a lot of direct pressure right into those tissues because that can be pretty uncomfortable. This is another good place that I found that some active engagement techniques work really well to help reduce tightness in these posterior cervical muscles. So what this means is we have to recognize when our client is engaged in a concentric or shortening contraction and when they may be involved with an eccentric or elongating contraction. We'll use the eccentric phase of that contraction to perform a stripping technique on those posterior cervical muscles, and that's a great way to encourage elongation, decrease muscle tone, and work those posterior cervical muscles without putting a lot of adverse pressure on them. Let's take a look at what that looks like.
During active engagement techniques, there is greater density to the muscle, which allows more effective penetration of the pressure, leading to greater tissue elongation. Eccentric muscle actions are used for this technique, so refresh your understanding of eccentric actions to perform these techniques effectively. Place one hand underneath the client's head and the other hand in a position where you can perform a deep stripping technique on the posterior cervical muscles with a small contact surface, such as the thumb or fingertips. Instruct the client to push their head down into your hand, which engages the posterior cervical muscles. So if you will, Barbara, press down against my hand. That's good. And now slowly let that go. As the client slowly lets that contraction go, an eccentric action is happening in the posterior cervical muscles as her head is lifted into flexion. At the same time, there is a stripping technique performed on the posterior cervical muscles. Again, hold this here and push down against my hand. And now slowly let that go. The active eccentric elongation performed while the stripping technique is applied to the posterior cervical muscles greatly enhances tissue flexibility.
One of the things that we routinely see with a lot of neck pain and injury complaints is problems with people being able to turn their head from one side to the other. They'll say that it hurts or it's painful or they can't turn to one side as much as they can turn to the other side. And a lot of times it's these ipsilateral rotator muscles on the back side of the neck that are causing the problem. Let's take a look. Here we show the splenius capitis muscle, which is one of the main ipsilateral rotator muscles. I'll turn a little bit to the side and you can see here this muscle on the right side. We refer to this as an ipsilateral rotator, and what that means is the muscle on the right side of the head or the right side of the neck turns the head to the right. A contralateral rotator is one where the muscle on the right side turns the head to the opposite side. A good example of a contralateral rotator is the sternocleidomastoid or SCM muscle. Let's take a look at it here. We can see the same thing, this time the muscle on the right side, if it contracts, it's going to have a tendency to pull this way, which is going to pull the posterior aspect of the occiput in that same direction. You can see that will turn the head to the left. So the muscle on the right side turns the head to the left, and we call that a contralateral rotator. Now, one of the challenges of working some of these muscles, especially the rotational muscles in the neck, is after various injury conditions, or in many people who just have limited range of motion, they can be quite painful. And oftentimes it's small and even subtle movements of the head and neck, just turning a little bit to one side or the other, that's really quite painful. And the more that pain ramps up, the greater is the resistance to being able to move. So what we have to do is to try to find a way to gently get those muscles to let go and relax. Sometimes just pulling and stretching some of the soft tissues on the side of the neck, just like in sort of a myofascial technique, can be a very effective way to do that. Here's an example of what that might look like working on some of the cervical muscles here, trying to get them to just relax and gently let go with just a soft, gentle pulling and stretching application applied to the superficial tissues. That gets some of those superficial nerves affected and sort of settles down the whole sort of wind up and irritability of the nervous system. In other cases, you can use the neurological system to help you in a slightly different way by using the principle of reciprocal inhibition. You probably heard that term before, but again, just to review what we're talking about, reciprocal inhibition means essentially you have muscle on one side that is inhibited because of an action on the opposite side. So for example, if we look at the splenius capitis muscle, and let's say this muscle here on the right side of the neck is the one that we want to focus on. That's the muscle that's really tight, problematic. And so the muscle on the opposite side, the left side, splenius capitis, we're going to try to contract that muscle first and then encourage stretching or elongation in the right side by contracting the one on the left side. So we'll do this with a reciprocal inhibition rotational stretch of the cervical region. So let's take a look. Here's what that'll look like.
Place one hand under the client's head in a position where you can turn the head to each side. Place one hand on the client's forehead and instruct them to hold this position, hold, and then relax. And turn into rotation to the opposite side. In this instance, stretching the right side ipsilateral rotators with reciprocal inhibition by engaging those on the left. This is a conservative variation that can be used if the client has more limited range of motion. The client contracts the ipsilateral rotators on the right side to engage reciprocal inhibition of the left. The client then relaxes and you rotate the head to the right. Rather than returning to neutral, the process is repeated from the stretch position. This can be performed several times until a full stretch is reached with these target muscles. Whiplash and other sudden neck injuries often cause acute spasm in the lateral flexors of the neck. The following technique is another reciprocal inhibition stretch that can be very helpful in these kinds of injuries. Place one hand under the client's head so you can both provide resistance and move the head. The other stabilizes the client's shoulder. The client holds that position as you press their head toward their shoulder. The client relaxes and you stretch in a lateral flexion in the opposite direction. Incrementally repeat the stretching method several times until you have achieved the most effective increase in range of motion.
So now that we've looked at a number of the key structures around the cervical region that play a role in many pain and injury complaints, I want to broaden the scope just a little bit for rounding this discussion out here today and talk about something that's a little bit different than the anatomical structures that we usually think about with various different pain and injury complaints. There's been a lot of work in the whole pain science community to look at what are the key factors that lead to a person being in pain. The cervical region is certainly a place where this is a factor on a regular basis. As a result, we've sort of modified some of the long existing theories and concepts of pain, and one of those has been the emergence of what we refer to as the biopsychosocial model of pain. Here you can see this biopsychosocial model is really composed of three key component parts. The first is the biological, and that's what we tend to focus on a great deal. We focus on tissues, whether they're damaged, injured, sprained, strained, there's the trigger points. What is the nature of the biological tissue dysfunction? Is there a disc herniation? What is the nature of the physiological tissues that we're dealing with? And for the most part, that's been the primary focus for many people as the cause of neck pain and injury complaints. But now we recognize that it's not that simple at all. There are overlaying factors that also play a significant role in whether or not somebody will have pain, or whether that pain will be really significant and long-standing for a prolonged period of time. For example, psychological factors may play into this, like stresses from your job, stresses that you may be feeling at home, your sense of something that's going on that's just putting a great deal of pressure or weight on your life experience. These are all psychological factors that can influence whether or not you feel pain. Social factors can also play a big part of that. Again, whether or not you're in a culture where pain is okay for a certain type of complaint that you have, or whether it's not okay. These somewhat soft skills areas have a significant impact on whether or not you will feel pain. A lot of times you can see people getting very distracted from their pain because something else has come along that's gotten their attention, like they can forget about it for a while. That's a psychological and social overlay that tends to damper down the pain sensations that they've been feeling. So it's not that it's just ultimately simple and you can just say, oh, hey, just change the way you think and you'll get rid of your pain. It's not that simple at all, because these are three very significant interwoven and overlying factors that play a part in any pain complaint that a person is going to have. Now, since as massage therapists, we've been focused a great deal on what goes on with the biological tissues. That brings up a new question, which is, how do we deal with this from a massage perspective? What it essentially means is, the more we can take into consideration about a broad spectrum of how a person may be feeling pain or may be experiencing pain in their body, the better we can be at being able to help them. So instead of just chasing down looking for specific tissue damage all the time, look at some of these other factors and see how they may be playing a part in what's going on with that particular individual. Now, this can become particularly challenging and difficult because it means you may have to really focus on some new skill sets that you have. Like, we're not really trained to be counselors in the massage profession, and nobody's asking you to be a counselor, but being aware of some of the psychological factors that overlay each individual client's complaint can be a really key part of helping them feel better. In many cases in the healthcare world, we have had lots of discussions and examples where a person felt that their quality of care was directly related to how compassionate the individual was, regardless of what they did for them. This has been done in psychology and in manual therapy and clinical rounds and with physicians. In many instances, the way in which you engage and interact with your client has a huge impact on how effective your treatment is going to be with them. So just being compassionate and caring is often, very powerful and can override the importance of specific techniques that you might be doing. So don't get too wrapped in feeling like you have to know X number of specific techniques to deal with certain pain and injury complaints. A lot of times what's more important is that you do really good basic work and just do it exceptionally well. So these are some key factors to keep in mind when you're looking at various pain and injury complaints that you might be working with in the cervical region. As you know, there's no shortage of people out there with neck pain who would love to have you come help them. So take some time to really focus on what you can do to help make their pain and injury complaints and their whole life experience a whole lot better. So thank you very much for having this opportunity to share some ideas with you. I'd love to work with you further. We have some additional training programs that we do through the Academy of Clinical Massage, focusing specifically on cervical pain complaints. And I'd love to have you come take a look at what we're doing over there with our comprehensive online training program. Here's our web address where you can find out more about it. We're located at www.academyofclinicalmassage.com. So once again, thank you very much to the ABMP for giving us this opportunity to present some key concepts on cervical pain complaints with the Neck and Head Summit. And thanks again very much for your attention. I look forward to working with you in the future.
Thank you, Whitney. For more information about Whitney's products and his workshops, visit his website.
If you're an ABMP member, you won't want to miss out on October 10th, when we will host Eric Dalton in an exclusive member-only online event to help you solve your clients' pain and injury puzzles. You've never seen techniques quite like these or experienced therapeutic outcomes quite so quickly. This work will change your practice and thrill your clients. Set up your computer, set up your massage table, and find a lucky friend to be your practice body, and work right along with Eric as he walks you through, step by step, each unique technique. Ask Eric questions in real time through live online chat and take quizzes for up to 6 hours of certificates of completion for continuing education. Nothing like this has ever been offered in Massage and Bodywork CE, and only ABMP members get it. If you have massage therapy friends, encourage them to join ABMP now to participate in this one-time only event. We'll see ABMP members right back here with Eric Dalton on October 10th.
Hello, I'm Leslie Young, ABMP Vice President Communication and Editor of Massage and Bodywork magazine. I'm honored to introduce our next presenter. Whitney Lowe is one of the first individuals who helped orient me to the field. He's a longtime contributor to Massage and Bodywork magazine and currently writes a column titled Science of Nerves. Whitney's career spans nearly 3 decades and includes extensive clinical work, research, publication, and teaching in advanced massage principles. He offers orthopedic massage certification and is the author of Orthopedic Assessment in Massage Therapy, widely used in schools and by professionals. Students enjoy Whitney's accessible, well-designed trainings, as well as the personal attention they get in his online trainings. Today, Whitney helps us demystify complex neck conditions in his session at the ABMP Head and Neck Summit. Understanding how to evaluate the client's condition is paramount to effective treatment, and Whitney will show us how. I'm sure you'll learn a great deal from his session. Please continue to enjoy Whitney's wisdom in Massage and Bodywork magazine.
Hi, my name is Whitney Lowe, and I'd like to welcome you to the 2016 ABMP Head and Neck Summit. It's quite an honor to be part of this wonderful group of presenters, giving you some great information here today about treating pain problems in the head and neck region. In this presentation, we're going to look at some key anatomical factors that help guide and to help you determine what kind of problems you're going to be addressing and some of the things that will be happening with each of those different pathologies in the head and neck region. It's really important to have a good understanding of many of these anatomical factors and some of the biomechanical characteristics in this area, because they play a big part in guiding the type of injury conditions that you're likely to encounter. So we'll look at a number of these different structures, some key assessment strategies, and also discuss some primary treatment processes that will be very helpful for addressing a wide variety of pain and injury conditions in this area. So let's get started. So we're going to take a look at some of the cranium from these very short muscles, so they're pretty significant. The challenge that we often have in trying to address these muscles from a treatment perspective is some of the overlying tissues that can get in the way. Let's take a look, for example. If we look at some of the most superficial tissues, we of course have the large trapezius, the upper trapezius section that lies over directly over this area. We also have the splenius capitis highlighted here, and also a little bit around the side. We have splenius capitis right here. We have semispinalis capitis that we had highlighted right here. Splenius capitis around the side, which is an ipsilateral rotator. We're going to take a look at it in just a few moments as well. Now, trying to work through some of these larger muscles to get to those suboccipital muscles is a little challenging. We don't want to just have to keep pushing on there with greater and greater pressure. So we often try to find some other helpful ways that will let us get in there a little bit more effectively. Working on these tissues right here, there's a concern that I want you to be aware of that may be a potential problem in this area. Let's take this semispinalis off for just a second and take a look once again back at our superficial, or our deep suboccipital group here. We have arterial structures in this area as well. And let's remove those muscles for a second so we can take a good look at those arteries. You'll notice the vertebral arteries travel through these small holes or foramen in the transverse process. We can see them right here. It's an unusual pattern for the arteries to be traveling through this little hole in the bone in the vertebrae themselves. Very few places do you see this kind of thing happening in the body. Now we have a problem here in the structure and the arrangement of these vertebral arteries, in that they go up on each side and then they blend together and eventually form the basilar artery as they go into the cranium. Now, if you put pressure in this area, you can cause a blockage of blood flow from those vertebral arteries into the brain. This can also happen if a person tilts their head back like that in full extension, or sometimes tilts it back and rotates it in a direction like that. That can cause a compression right in this area right here of those vertebral arteries. And when it does cause compression of those vertebral arteries, that may block blood flow to the brain, and the person may feel dizzy or lightheaded, or they may have ringing in their ears or buzzing or seeing stars. Any type of neurological sensation like that that causes them to be somewhat disoriented can be a problem, so you don't want to do that. So a couple of things that you can do to keep that from being a problem is, just as a general guideline, it's a good idea not to work both sides of the neck in this region at the same time. Let's look at those muscles once again. We're often trying to focus on these suboccipital muscles, and you can see how they're lying directly over those vertebral arteries. Let's just fade them for a second. And we can see those vertebral arteries right in this whole area here, with those muscles faded looking over the top of them. So you can see the pressure in this area could potentially press on these sensitive arterial structures. So as I mentioned, just try not to press both sides at the same time, and make sure you let your client know, if you're working on any of those deep suboccipital muscles, to let you know if they have any sensations of dizziness, lightheadedness, or anything that might indicate some key anatomical structures here that may play a role in a number of pain and injury complaints around the cervical region. The first thing I want to call your attention to is the deepest structures there, the structure of the bones of this region, because they do play a part in a lot of different things that we're going to be addressing as a massage therapist. This area is not very structurally sound from the skeletal standpoint, and as a result, we rely a great deal on soft tissues to give us some additional stability in this area. Let's take a look here. You can see the bones of the cervical region and the contact surface between adjacent vertebrae as we sort of move our friend around here. And do take note here too, the head It's got a significant amount of weight, but the contact point of where the head is articulating with the cervical vertebra is actually very small. It's just this little amount here right at the atlanto-occipital joint. So there's not a lot of contact surface here, and we rely on structures such as the joint capsules, various stabilizing ligament structures, and a number of others to provide additional stability in this region. Let's take a look at some of the real important muscles that play a role in stability in this region too. They also have a lot to do with creating and producing movement here between the atlas and the occiput. You may remember from your anatomical studies back in school having to remember all of these muscle names, and these were some of the most challenging ones. I always think about this as being interesting because you have some of these small, really short, some of the smallest and shortest muscles in the body with some of the most long and obnoxious names to them, like rectus capitis posterior minor and rectus capitis posterior major. These are very important muscles. They also play a big role in a lot of headache pain complaints because trigger point pain referral patterns can often go